Coming up today, surgery now to prevent cancer later. Meet someone who chose to remove her breast without a diagnosis. Plus, how to know if you are at a higher risk. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. How far would you go to prevent yourself from getting cancer? Would you quit smoking, eat better, exercise more? If you're a woman, would you ever consider having your breasts surgically removed? You may remember that's exactly what actress Angelina Jolie did back in 2013 after learning that she carried a genetic mutation that put her at a much higher risk of developing breast cancer. Since then, more and more women with the same BRCA mutation have turned to preventative or prophylactic mastectomies. Today, we are exploring how someone navigates that decision and who should consider having a preventative mastectomy. And of course, what are the pros and cons? Mackenzie Patrick made this choice when she found out that she had the BRCA2 gene mutation. We're going to hear from her and her doctor here in just a few moments. But first, let's get to our morning rounds. Lung cancer is the leading cause of cancer deaths in the U.S., and hospitals nationwide are pushing for early detection by offering lung cancer screenings tomorrow, November 9th. We want to say a huge thank you to everyone who signed up for those screenings. There are actually no more slots available here at the University of Kansas Health System, but if you did not get a spot, you should still be asking your doctor about this screening. This morning, we are joined by Dr. Krishna Reddy, a radiation oncologist with the health system. Good morning. How are you?
Good morning, Jessica. I'm fine. Thank you so much for having me this morning.
Yes, thanks for being here to talk about this. The screenings that we're talking about, they're called a low-dose CT scan. And under the current guidelines, it's not for everyone. So who qualifies?
Yeah, so the guidelines were updated a few years ago. Anybody who's age 50 to 80 who has a 20-pack year history of smoking or more is eligible. And there's no limit on when somebody quit smoking, meaning how many years ago they smoked. Somebody could be a current smoker, or they could have smoked and quit 30 years ago or more, and they would still be eligible as long as they're between 50 to 80 years old and have 20-pack years or more.
Remind us what a pack year is.
Yeah, so a pack year is just the number of years you smoked multiplied by the number of packs per day that somebody was smoking. So for instance, if someone smoked a pack a day for 20 years, they would meet that 20-pack year limit or 20-pack year kind of criteria. If someone smoked 2 packs a day, then in just 10 years, they would meet that 20-pack year criteria.
All right, so just do the math. The CT scan itself, though, pretty straightforward, Dr. Reddy. What should someone expect?
Yeah, so it's just a regular CT scan. You basically lay on a table, pass through the CT scanner. It's basically X-ray, so it's invisible. You don't feel anything during the procedure. It only takes a couple of minutes. And it's the CT scanner itself is kind of like a donut. So it's, it's not enclosed like an MRI for people who are worried that they would be, claustrophobic. It's basically open. You just quickly pass through the donut in just a couple of minutes.
Oh, that's a good point to make. So let me ask you, if someone has a history of smoking, but they're not sure if they officially qualify under those guidelines, can they pay out of pocket? And if so, how much would that cost them?
Yeah, so the first thing I encourage everybody to do is talk to their primary care provider about this, because many people are actually eligible and don't realize it. And studies have actually shown that the number one reason that people don't get these low-dose screening CTs is because their healthcare providers just haven't discussed them, or it hasn't been communicated in a way that's clear. And so patients can, potentially pay out of pocket, but I think it does depend a little bit on someone's individual insurance. These are approved by Medicare. They are approved by commercial insurers for eligible patients. So again, I really encourage everyone to talk to their primary care providers about it. Out of pocket, truthfully, the cost of a CAT scan probably varies a little bit depending on someone's insurance. I think if someone was specifically interested, they should probably talk to their primary care provider, and probably our KU radiology department could even provide some kind of a quote for what it would cost out of pocket for someone.
So, Doc, just big picture awareness. Just remind us, how does catching lung cancer early just really impact that treatment option and survivability?
Yeah, that's a great point, Jessica. So it's all about early detection, and that's the case for so many cancers, but absolutely the case for lung cancer as well. So our ability to cure lung cancer is definitely the best the earlier it's caught. And with early stages of lung cancer, which is what these low-dose screening CTs are trying to pick up, but we have an excellent chance of curing someone with lung cancer. The treatment options could be a surgery or even just targeted radiation non-invasively in just 5 treatments as an outpatient. So again, we have excellent chance of cure when we're able to pick up lung cancer early. And these eligible patients, qualify for a yearly low-dose screening CT. So again, I really encourage everyone to talk to their primary care doctors. Just a recently published study in the Journal of the American Medical Association found that only 10% of patients nationally who are eligible for these low-dose lung cancer screening CTs actually get them.
Dr. Reddy, always great to have you on to share your expertise. Thank you.
Thank you so much, Jessica.
Mutations in the BRCA1 and BRCA2 genes, they increase your risk of breast, ovarian, and other cancers. According to the National Cancer Institute, more than 60% of women who inherit a harmful change in one of those genes will develop breast cancer in their lifetime. Compare that to the general population, where just 13% of women will develop breast cancer. Once Mackenzie Patrick learned that she had the BRCA gene mutation, she decided she wasn't going to sit around and wait and see. She took action.
My aunt had been diagnosed with breast cancer. My dad had lung cancer. My grandma had leukemia. Grandpa had kidney cancer, all the cancers. Prostate cancer, pancreatic cancer, and like 2 great-grandpas.
Over time, as Mackenzie Patrick connected the dots of her family history, she knew she needed genetic testing.
Seeing all of the family members go through all their array of treatments, prognoses, things like that, I knew if I had a diagnosis of any mutation that would precurse me to cancer, I was like, I'm going to do whatever the doctors say is my strongest option to hopefully prevent that from happening to me.
Mackenzie did test positive for the BRCA2 mutation. Now it was decision time.
I know that I would feel better for my level of control in this to go forward with the prophylactic double mastectomy.
She had other options like increased screenings and surveillance at the high-risk breast cancer clinic at the University of Kansas Cancer Center. But even at just 26 years old, Mackenzie wasn't waiting because she knew the statistics.
I believe with the BRCA2 mutation, I had above an 80, probably around 85% chance of a breast cancer in my lifetime. And then by doing the prophylactic double mastectomy, it took me down then less than 1 to 5%.
Mackenzie talked with her husband, who listened closely and said,
I feel like I talk out loud to him. Like he's like, I'm in the discussion, but I'm mostly just listening to let you walk through it when you talk. And I'm like, okay. And so he was like, whatever you think works best for you, your goals, your body.
Mackenzie had her double mastectomy and later reconstruction surgery, moving forward with peace of mind.
It was a pill to swallow in a sense of what you realistically think of your life plan. If I can save myself potential chemo, radiation, whatever they have to offer, I would love to not go through any of that.
And we welcome Mackenzie Patrick to our program this morning, along with her breast surgical oncologist, Dr. Kelsey Larson. Dr. Larson, good morning.
Good morning. Thanks for having us.
Good to have you. Mackenzie, nice to have you as well. Thank you
for having me.
So tell us how long it's been since this double mastectomy.
So I had my procedure in February of this year, and then the subsequent continued reconstruction I finished out this August as well. So all done with my big 3, which is different for everybody, but I was excited to be done in a year.
I bet. So let's start back with this genetic test. You decided to get one. Did you have a hunch that it might come back positive for the BRCA2 gene mutation?
Yes. After my aunt had told me you should look into genetic testing based off of what my doctors told me, I was like, that means there's probably a good chance that I will have to figure that out. And so, yes, going in, I had more planned for the worst case scenario in my mind than the best.
Well, I was going to ask you, we always talk about, knowing your health history, and some people want to know and some don't. Were you excited to find out so that you could get ahead of things and start down that path, or were you a little hesitant to take a genetic test?
I think I was more excited to sort that out because I knew my continued life plans, when people ask you, what do you see in 10 years? Do you have a family? Do you have your career? All those choices I felt could be impacted by finding this out in the middle of that randomly. Whereas if I just got that off my table to start, my dominoes fell a lot easier.
That's a smart girl. Okay, tell us about the genetic test. What was it like?
It was really simple for me. It was just a spit tube, but some of them are blood draw. But the provider I saw had the I'm forgetting the company's name.
All right.
But it was just spit, so it was really easy. The hardest part was figuring out where to go.
Well, that was what I was going to say. Is you get this genetic test, and then you have all these experts. Who does it go in the hands of? Who are you having those first initial discussions with?
So I originally saw Mary McCarthy in the High Risk Breast Cancer Center, and that's where kind of the in-depth conversation first started with. I finally had my foot in the door, and this was an individual who knew this specialty to tell me my options.
So did you meet with a genetic counselor?
I did not. Knowing that I wanted to go forward with it and just kind of figure it out, I didn't feel that that was necessary, but that's an option for folks.
For people who don't know, but you sounds like you kind of just already knew and had your mind made up.
Yeah, a little bit.
This is nice. Okay, so you learn you have this mutation, but it's not a guarantee that you're going to develop cancer. Walk us through some of those pros and cons that you listed out, deciding if you were going to go forward with this double mastectomy.
So my pros and cons kind of came down to pro, reducing my risk to lower than the average woman's risk. Con, it's a major surgery, not to be taken lightly, and it was, I had to plan for downtime, when it would work out with my life. But I think what came down to making the decision was what made me comfortable with the level of control that I had in the situation. And whether that be reducing the control and just letting it go to somebody else and putting it in the back of my mind, or grabbing it as much as I can to do as much as I can. And I just leaned towards grabbing everything I could.
So Mackenzie, a woman's breasts, we know, are personal. What questions did you have about the procedure? Or when you sat back and thought through all that, how did that play out in your head?
It was definitely a different sense of self originally, pardon me, but it, over the time, transitioned into, it became my new self, and I don't feel any different as a woman or as an individual with this new sense of self.
Dr. Larson, let's bring you in here because we mentioned the Angelina Jolie effect. I want to ask you, because I remember that's the first time I really heard about it. I remember when this happened, when she had those, it was like, whoa, that's so drastic. We really had never heard of anyone doing it, even perhaps people had been doing it. But how has that over time, how did that help really give women an option and kind of lay that out there so people knew that this was something they could do?
Sure. I think the most important thing, as Mackenzie outlined, is that women have the option of understanding their risk. And so if someone wants to be proactive about trying to prevent cancer, whether that's through increased screening or through surgical intervention, meeting with people like the high-risk team. So Mackenzie saw Mary McCarthy. We have a lot of high-risk, wonderful providers. They can tell you what your lifetime risk of cancer is, and they can give you options to stay on top of things. So Angelina Jolie really helped us to be able to have those conversations about, we want you to be proactive in some way, shape, and form. Let's open the door to having that discussion.
So how long has this option been available?
Well, the genetic testing has been around for some time, and BRCA genes were some of the first that were identified as being associated with cancer. So what has happened is, as the genetic testing has become more prevalent, we also have gotten improved techniques in terms of surgery and surgical safety. So the genetic testing increasing in frequency, appropriately so, has come alongside having safer operations and safer operative options. So it's really grown, I would say, over the last 10, 15 years in particular, to be a good, at least, conversation for women to consider.
So how do you have those conversations with women about outweighing the risk of cancer against the risk of possible complications of surgery?
Sure. So from a national level, there are quite clear guidelines about patients who may benefit or who may consider risk-reducing mastectomy. There are women who are at slightly elevated risks of breast cancer who would not qualify because, as you said, the risk of surgery does not outweigh some of the other risk factors. But basically, we have a high-risk team who helps patients to stay on top of their breast health. And then when someone wants to consider, learn a little bit more about surgery, we meet with them. We can talk about the pros and cons of the surgery, what to expect, as Mackenzie was outlining, in terms of recovery. And then patients can make their own decision based on that information about what route might be good for them.
Dr. Larson, we know undergoing a double mastectomy, it's a big decision, maybe easier for some women, but what has been your experience when having those conversations with patients who come to you with just different ideas about this as an option?
Most of the time, it is a little bit more common for me to meet with patients, and I say we're on a fact-finding mission. So there's great information on the internet and online about these types of procedures, but most of the time when I meet someone for the first visit, they just want the medical facts for their particular case and to ask some detailed questions about how their particular surgery would go. It's pretty common for me to meet with patients a couple times as they're making that decision. For some people, it's once or twice over a few months. For some people, I might meet them once a year for 2, 3, 4 years as they gather that information and decide what's right for them.
So is a genetic mutation required in order to get a risk-reducing mastectomy? I mean, can somebody seek one out just based on family history alone? Mom, grandma, aunt has had breast cancer and they come to you with that history?
Yeah, that's a great question. There is a lot of misinformation out there. So a couple family members with a diagnosis of breast cancer would not qualify someone for risk-reducing mastectomy. As I mentioned, there are risks of the surgery and there are national guidelines. Most of them do center around patients with certain genetic mutations. But what is important to highlight is that family history may mean that you should get that genetic test. So what we recommend is that patients start with a high-risk breast cancer expert, such as we have here at KU or other centers, or start with a genetic counselor. They can help to talk to you about genetic testing, help to get that risk assessment, because really the family history informs if you should have genetic testing. That helps us understand who would qualify for the surgery.
Let's talk timing. If someone learns that they have this mutation, do they need to get the risk-reducing surgery before a certain age?
That is actually one of the questions that we would love to be able to give people a specific answer to. And the answer is we're not totally sure. So usually what we do is we look at people's family history. You have a lot of family members that are getting breast cancer in their 30s. That may be something you want to consider doing at a younger age. If you have a lot of family members getting breast cancer in their 50s, maybe that's something you consider differently. But it's really hard to calculate a year-by-year risk that someone has for breast cancer. So really, it's the time that's right for you. Mackenzie was very proactive, and that was perfect for her. I have plenty of patients who are in their 40s and 50s, and that's the best time for them.
So who should consider getting the genetic testing? Just if you have a history, or would you get a genetic test even if you had no history, just to make sure?
Yeah, great question. So patients who really need to speak to their doctors about genetic testing, if you have any family history of ovarian cancer or pancreatic cancer, those are big flags that we want to know about. If you have breast cancer in relatives at a young age, so under the age of 40, or in multiple relatives, let's say mom, sibling, aunts, that would be someone that we would want to make sure was offered or at least discuss genetic testing.
So who orders the genetic test?
Yeah, it actually depends health system to health system. So here we have genetic counselors who can order it. We also have high-risk breast cancer prevention team that can order that test. Occasionally, people's primary care and GYN physicians have the authority to order it, but it is a different prescribing authority than a typical, let's say, blood count or something like that. So it does have to be someone who has that background and that training to do so.
Mackenzie, you have a sister. Did you have conversations after you had your genetic test, and what were those like?
Yes, it was very much so, sisters, supporting each other, and she's like, well, whatever you need, I'll be there. And then I was like, well, we also should talk about you. We need to support you and, figure out if you're interested in this. And it was very helpful to have somebody to go through it with, even if we didn't test the same.
So you didn't. So she tested negative for the mutation. Dr. Larson, is that typical? One sibling has it, one sibling doesn't?
Yeah, these particular genes are passed on about 50-50. So genes are inherited from our parents in a little bit different ways. And for the BRCA genes in particular, it's about a 50-50 shot that children would get that gene from their parent.
Mackenzie, you work in healthcare. Did that have any impact as you headed down this path when you went in to have your mastectomy, the reconstruction? How did that help your experience?
It was very helpful because I felt like, again, control was a big thing for me, so I felt like I had more knowledge, but then again, I was like, please tell me everything you know. I don't know everything.
Yeah, right.
We're talking to the experts.
Right?
But then giving myself grace was, I think, the hardest part of, you are, a patient, you're going to have to recover, you're going to try to push yourself, just
you're one of the, I know, typical people in healthcare, right? Dr. Larson, they just want to jump up and get back at it.
That's always how it is. And actually, Mackenzie makes a good point in that many of our patients do very well after surgery. So, not to downplay the recovery or discomfort or things, but we have a lot of conversations about restrictions, allowing yourself time to heal, allowing yourself that time to recover. So, that's important that everyone feels that they have the permission to do so.
Well, yeah, and a good point, because that's going to go into someone's decision. A young person who technically may not need it, needing to take in consideration their downtime. So good thing to point out. Be sure to ask your questions. You can use the chat on YouTube or Facebook. You can email the Medical News Network. The information is there on your screen. Dr. Larson, we've been focused on breast cancer, but the BRCA mutation puts people at high risk for other cancers. How do patients benefit then from seeing a high-risk cancer prevention expert?
Sure. So for many different types of cancers, there is increased screening that someone can do. And increased screening simply means that there are opportunities for you to do imaging or blood draws or certain types of tests a little bit more frequently than the general population to keep on top of your personal health and to keep on top of your cancer health. So each particular gene has differing risks of differing cancers, and those high-risk doctors can say for your gene, your particular family history, your situation, what should you be doing just to stay on top of your health?
So besides BRCA, what other gene mutations might make someone eligible for the risk-reducing mastectomy?
So BRCA genes are the ones that we most frequently see patients for. Of all of the genes that are related to breast cancer, that is one of the most common. So I would say those are the ones that we commonly are talking to people about. Some of the other genes are a little bit loosely associated with breast cancer. So then when we're talking about surgery, we're trying to figure out between their gene as well as their family history, is this really relating to breast cancer, or maybe more relating to other types of cancer like colon cancer or something like that.
So how often do you see a patient like Mackenzie seeking out this type of surgery if they have that gene mutation?
I would say a reasonable number of patients do choose to undergo the surgical intervention to lower their risk, but we also have a ton of patients who are not ready for surgery, or maybe surgery is never going to be right for them, and they do increased screening. And so the increased screening, again, just means that they're getting checked a little bit more often. From a physician standpoint, we see patients almost weekly to have these conversations. So we want to make sure we're answering people's questions and getting them the information they need for their own personal decision.
So if someone finds out they have this mutation, kind of walk us through the patient flow. Do they start with their PCP?
So it depends a little bit on who orders the genetic test. Usually what we do is we try to help someone get in with a genetic counselor or a high-risk breast cancer or other cancer expert, because they can get you in with all the expert care and all the things that you need. So in Mackenzie's instance, our breast cancer prevention team ordered her genetic testing and then helped her get in with all the other specialties she needed as far as screening and prevention. So usually that's how someone would go through the process, is whoever orders the test would start getting them in with the individuals that they need to see. And in our patients, most commonly, they start with a breast cancer prevention team to offer increased screening, and they wouldn't meet with a surgeon unless they were interested in learning more. Some patients are really interested in that, meet with us right away. Some people, it's not on the table for them, they prefer not to, and that's no problem as well.
Dr. Larson, what other type of preventative care do you offer at the high-risk clinic?
So many patients who are eligible can undergo increased screening. And increased screening means that you would do a yearly mammogram, alternating with an additional test, such as a breast MRI, ultrasound, or contrast mammogram. So the idea with increased screening is that you can try to find something at a smaller size and catch something earlier. Very similar to what we were talking about the lung cancer screening, the sooner we can find it, the sooner we can detect it, the better we can do in terms of cure and treatment for that.
I want to get to some questions from our community this morning. And Jeremy has one. After a mastectomy, are there other ramifications like affecting hormone levels? I assume it's not as simple on the body as losing a finger or a foot or something like that, he says.
That's a great question. So breast tissue itself does not produce or make any hormones. Breast tissue is made of fat and ducts and lobules that respond to the hormones that are made elsewhere in our body. So it is basically an operation that removes the fatty tissue, the ducts, and the lobules. But in terms of overall hormonal health or cycles or things like that, it actually does not have an impact.
Susan wants to know if Mackenzie will still need to get mammograms, or what other screening might she need in the future.
great question. After someone undergoes bilateral mastectomy, there is actually no more routine screening or imaging. As Mackenzie highlighted, the risk of breast cancer is not zero. It's very low, between 1% and 5% in someone's lifetime. And any cells that are left would be between the skin and the reconstruction, or between the skin and the muscle. So simple skin exams that can be done by a primary care or GYN is all that would be needed.
Becca wants to know, are you more likely to carry one of the BRCA gene mutations if the family history is on your paternal or maternal side?
That is a great question. So breast cancer genes can come from either dad's side or mom's side. So when we ask about family history, we really want to know about both sides of the family. This is something that can be passed from either parent.
It's a big science question here, Dr. Larson. So just tell us, if you can, in very layman's terms so I can understand, what is it exactly Lauren wants to know about this mutation that puts you at such an increased risk of cancer? Why this specific gene and mutation?
Sure. So our cells in our body are always going through normal and natural cell cycles of growth and division. And of course, that's a very complicated process. And of course, when the cells are going through these normal cell cycles of growth and division, little errors or little irregularities are made. There are certain genes that basically correct these irregularities or these little errors so that our cells grow and divide in a normal manner. When people have genetic mutations that predispose them to cancer, basically those correction mechanisms are not in place or are not as strong. And so when our cells are growing and dividing, the natural normal little errors or little mistakes that are made, our genes that usually would fix those, they don't function as well. So then the errors happen at the same rate as everyone else, but we don't have that backup or that support system to try to get those corrected within our bodies. So that predisposes us to having cells that continue to grow rather than having those genes that repair the little errors that come up.
Dr. Larson, what's the big takeaway today when it comes to the decision of whether or whether not to get a risk-reducing mastectomy?
I think two big takeaways. First is to make sure that you know your family history and talk to your physicians about that. We want everyone to understand that there are tests that can help you understand your risk of cancer, all types of cancer, and that you can be proactive about your cancer health by getting some more information if that's what you're interested in. And from a surgery standpoint, there are certain individuals who definitely qualify. But even if you're not an individual that qualifies from the surgery standpoint, there are still things that can be offered so you can be more proactive and make sure you're keeping healthy and safe.
Great info this morning. Thank you so much. Mackenzie, what is the big takeaway from your story?
I would say it's, think of it as it's easy enough to start with talking to your primary care about this, and then everybody's life is different, and what's best for you may be different than everybody next to you, or vice versa, and it's always okay just to have the discussion.
Thank you for sharing your story. Be well. Be well. Thank you to both of our guests. Thanks to our viewers for being with us today. Have a great weekend, and we will see you back here on Monday.
Coming up Monday on the Morning Medical Update. Her doctors thought she suffered a stroke in high school, but it turns out her own immune system was attacking her brain. I'm Alexis Del Cid on the next Morning Medical Update. The years-long path to a proper diagnosis and the life-changing treatment that finally lets her hold down a job and live independently. Monday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.